So my name is Marion Subklewe. I work as an attending in the hematology oncology department of the LMU University of Munich, and I'm heading the T-cell bispecifics in CAR-T program at our institution. Today, I'd like to share some thoughts on CAR T-cell therapy in MCL and how this probably will shape the landscape of MCL treatment. So currently, the standard, at least at our institution, in younger and fit MCL patients is still immunochemo-based induction therapy, followed by an autologous stem cell transplant for consolidation treatment. In the relapse setting, second-line BTK inhibition with ibrutinib or acalabrutinib are standard with an overall duration of response in this setting of 1 to 1.5 years. We have parameters at hand that define high-risk group of patients, and these include blastoid or pleomorphic variant, Ki67 over 30% and P53 alterations. We know that this high-risk cohort is an overall survival of less than 4 years and behaves quite differently from a more chronic MCL. So these were exactly the patients treated within the ZUMA-2 trial, testing CD19 CAR T cells in high-risk relapsed refractory mantle cell lymphoma patients. 74 patients were enrolled and 68 patients treated, with 31 being of blastoid or pleomorphic variant, 82 of the patients having a Ki67 over 30%, and 70% showing a P53 mutations. All patients had received prior anthracycline or bendamustine containing chemo regimens, including an anti-CD20 antibody and BTK inhibition. The results were remarkable, with an overall response rate of 93%, a CR rate of 67%, with a median follow-up of now 12.3 months. 57 of the patients remained disease-free, with estimated 12 months progression-free survival and overall survival rates of 61 and 83%. Accordingly, approval of Brexocel, the sister molecule of CD19 CAR T-cell product axi-cel, already approved for aggressive lymphoma, was FDA and EMA approved. The difference of Brexocel compared to axi-cel is the manufacturing step, with selection of CD4 and CD8 T cells from the leukapheresis product to eliminate any contaminating MCL cells. The difference between the FDA and EMA approval is that in the US, the approval is broader, given to any relapse refractory MCL, whereas in Europe, the approval was given closer to the inclusion criteria of the ZUMA-2 trial, only for third-line therapy after failure of chemo and BTK inhibitor therapy. Although clearly the follow-up of a very small still patient population treated in the ZUMA-2 trial is still short, 1 year, one can already speculate how this will change the treatment landscape of MCL. I also like to highlight 2 other trials showing that ibrutinib concurrent to leukapheresis and CAR T-cell therapy appears safe with a lower CRS rate and higher response rate, at least shown in the setting of CLL. Also, there was an interesting trial recently published in Blood, the Oasis trial, testing the combination of ibrutinib, obinutuzumab, and venetoclax in relapsed refractory MCL, but also in first-line therapy, very small patient population, but in the untreated MRD evaluable patients, MRD clearance was achieved in 100% of the patients. So this makes me envision a chemo-free scenario in MCL patients in the future. I think we most likely have to stratify therapeutic approaches according to the risk profile, but particularly in the high-risk patient population, I could envision a BTK combination therapy in first line, followed by a consolidation with CAR T cells, potentially MRD driven. I think we need to understand the benefit of prior BTK therapy or concomitant BTK therapy on CAR T cell product and safety and outcome in the MCL setting. And although it is too early, but I envision a chemo-free concept But this has to be looked at with caution, despite all the enthusiasm, as we still have a very short follow-up after CAR T-cell therapy.